Hello everyone, my name is Wahajuddin Mohammed and today I will be presenting a very interesting case report of a patient with a rare presentation of idiopathic serositis, which was later on complicated by a hemopericardium formation. My co-authors for this report are Lay Pandya and Dr. Zaryab Khan, and this was done in affiliation with Ohio University Heritage College of Osteopathic Medicine and Ohio Health Doctors Hospital. So what is serositis? Serositis refers to inflammation of the serous tissues. It is usually caused by infectious, neoplastic, or autoimmune disorders and can affect various anatomical sites. For example, inflammation of the pleura of the lungs is called pleuritis, inflammation of the pericardium of the heart is called pericarditis, and inflammation of the abdominal peritoneum can be referred to as peritonitis. These inflammations can often lead to fluid buildup, resulting in pleural effusions, pericardial effusions, and ascites, respectively. Idiopathic serositis is when there is serositis without any known infectious, neoplastic, or autoimmune causes. It is hypothesized that idiopathic serositis could be due to dysregulated activation of innate immunity, suggesting an autoinflammatory origin. While no specific gene has been linked with idiopathic serositis, many cases exhibit elevated inflammatory markers during acute episodes, and medications such as colchicine and IL-1 antagonists being effective also supports this hypothesis. Idiopathic serositis has limited data in the literature, which is why this case is interesting. Moving on to the case presentation, a 74-year-old male with no significant past medical history presented to the ED with worsening shortness of breath, palpitations, and chest pain that began 5 days prior. Initial EKG showed new onset AFib with RVR. This was managed with a diltiazem drip, which led to spontaneous conversion to normal sinus rhythm. EKG then showed infralateral ST elevations with ST depressions in AVR, V1, V2, and electrical alternans. They were concerned for a STEMI, so a left heart cath was done, which showed non-obstructive disease. The patient was started on dual antiplatelet therapy and unfractionated heparin and admitted to the hospital. Physical exam findings showed tachycardia, hypotension, JVD, and indistinct heart sounds, which correlate towards Beck's triad, suggesting a pericardial effusion with cardiac tamponade physiology. He also had adynamic troponins of 38, elevated BNP, lactate, and a leukocyte count. This is the patient's EKG. They were first concerned about a STEMI, but after the cath, this seemed more suggestive of pericarditis. On the following day, an echocardiogram was completed, which showed a large pericardial effusion with tamponade physiology, LV wall motion abnormality, and a low ejection fraction of 38%. Pericardiocentesis yielded 700 cc of bloody fluid with atypical reactive mesothelial cells and an elevated RBC count. Infectious workup was all negative. A rheumatic workup showed elevated ESR, CRP, and rheumatic factor. The patient was treated with ibuprofen and colchicine for his pericarditis, and anticoagulation was held due to the hemorrhagic effusion. In this echo, you can see the very large pericardial effusion on the side. On day 4 of admission, the patient experienced acute respiratory failure. CT showed a right pleural effusion indicative of a pneumonia, which yielded about 1,000 cc of bloody serosanguinous fluid. The CT also revealed multiple thoracic vertebrolytic lesions. A multiple myeloma evaluation was done and it was negative. An autoimmune workup was negative for ANA and CCP antibodies. To recap, idiopathic serositis occurs when infectious, neoplastic, and autoimmune causes of serositis are ruled out. This patient had a large pericardial effusion with serosanguinous fluid. Infectious workup was all negative. Autoimmune workup showed elevated ESR, CRP, and rheumatoid factor but negative ANA and CCP antibodies. Pericardiocentesis also showed atypical reactive mesothelial cells, but further workup did not show any neoplastic cause. Multiple myeloma workup was also negative. In conclusion, the unclear fluid analysis and workup findings support that this is a case of idiopathic serositis, which was complicated by a hemopericardium formation. Idiopathic serositis is very rare and not well documented in the literature, and this case gives insight into this condition, its workup, and potential complications. Thank you.